Dr. Matthew William will be speaking on role of LV support in AMI. He is from Columbia University, and in high risk angioplasty, primary angioplasty, LV support has a lot of role to play, and he will give us a clear indication of this thing.
So let's talk about. I'm going to be talking about our support options for LV support. A lot of the data really comes from cardiogenic shock, and less is from strictly AMI patients. So let's just kind of go over our options first. So I'd say the mainstay and really the gold standard for support right now is the intra-aortic balloon pump, and I think we have a very good understanding of how this works. The flow augmentation is limited, but it afterload reduces the heart. With some good effects. That being said, despite this being really the gold standard, there's really very limited data and really no randomized trial that demonstrates that this is a superior technology to even nothing alone. Moving on to some of the more elaborate devices, this is the tandem heart system. Which provides univentricular support. You can do biventricular support, though it would require 2 devices. But in the recommended confirmation through a transeptal puncture, the inflow cannula is placed into the left atrium, and then the outflow is placed into the femoral artery. With this system, in theory, you could flow 6 liters and more. The problem with it is, one, obviously it can be difficult to do this quickly in terms of needing to prepare for a transeptal puncture. Additionally, the system is quite expensive, certainly when you compare it to a balloon pump. And we also know that, sorry, I don't know where that advanced. We also know that doing left atrial decompression is not as good as decompressing the LV in terms of resting the heart. Another device is the Impella, and this has this basically rotor blade that sits in the aorta. The device sits in the left ventricle and basically withdraws blood from the left ventricle beyond out into the aorta. There are about 3 configurations of this device: a 2.5 liter device that is placed transfemorally. There's also a 5 liter device that's placed transfemorally, and then a 5 liter device that is placed more through a surgical approach. This is perhaps a little easier to place and quicker than the tandem heart that I already showed you, but perhaps a little less flow than you can get with the tandem heart device. It too is a very expensive device. There are some issues with hemolysis. The other issue is there's a lot of discussion whether a 2.5 device may not be enough for someone in frank cardiogenic shock. And the 5.0 device, which might be enough flow, is about a 21 French system. And while that's probably appropriate for many people when you're in cardiogenic shock and a lot of pressures, the vessels tend to be a lot smaller, and it can be more difficult to place this device. But in general, it's certainly much simpler than the devices requiring a transeptal puncture. Usually in a interventional cardiology meeting, when we're talking about these devices, there's not a lot of discussion about ECMO, but I think that this is an important component, and this is something that we've actually been relying on a little more in our institution, and I'll talk about it. And this device can be placed very quickly as long as you have it available, and usually you need some perfusionists to run the system. But at our institution, the surgeons typically place this, but the skills and the cannulas are available, and certainly any interventional cardiologist is able to do this. I think this is one of the quickest ways to get someone on support, and it easily provides full support. Problem is, it also does not decompress the ventricle very well. Another approach is just to consider a ventricular assisted device. My colleague Dr. Jordy talked yesterday about some of these devices, and I'm just kind of focusing on the short-term devices. This is an example of the Centramag device, which is the one that we tend to use, but essentially you could use any centrifugal flow device, even just a Biomedicus head that we frequently will use for a just for cardiopulmonary bypass procedures. You can get biventricular support and you decompress the heart well. And quite honestly, while this obviously looks like a lot with an open chest, in a emergency situation, I can, outside of perhaps a balloon pump and ECMO, this would be the fastest device for me to be able to place to get a patient on support, but obviously it's very invasive. So what about the data? So there's a couple studies I'd like to go over. The first is a study, and again, as I mentioned before, this is cardiogenic shock, which is frequently due to an MI, but not necessarily. This study randomized patients in a one-to-one fashion, balloon pump versus the tandem heart device, which again is the transeptal device that I showed you. The average support time was about 3.5 days in both groups. In terms of the mortalities, again, these are small numbers. There were 4 patients who died in the balloon pump group, all due to left ventricular failure. And in the tandem heart device, there were also 4 patients. However, only 1 died from LV failure, and 3 died from organ dysfunction. Sorry, this isn't working correctly, but they also looked at lactate production in these patients in shock, and basically those who had the tandem heart had the resolution of their lactate levels dropped much more quickly to normal levels as opposed to the balloon pump. But again, that didn't result in any meaningful clinical difference. Another trial looking at the Impella device, also randomized in cardiogenic shock against balloon pump, showed, looking at cardiac power index, which is a good predictor for in-hospital mortality, there was an initial improvement, more rapid with the Impella, but it equalized compared to the balloon pump. With the serum lactate, again, it was a little more rapid in the improvement with the Impella device, but it equalized after just a few hours of support. And most importantly, in terms of survival, there was no difference between those patients treated with an Impella 2.5 versus a balloon pump. I should also note in these trials with both the tandem heart and Impella, there were more bleeding access complications. There was a meta-analysis, and I say meta-analysis loosely since our total patients are about 100 patients, but looking at the 2 studies I showed you as well as another one, and basically there's, it's really split, and there's certainly in this population no clear advantage to ventricular support versus a balloon pump. But what about specifically the AMI patients? There was a registry in the U.S. that looked at Impella, and within that registry there was kind of a subgroup of patients who actually presented with acute MIs. And not a randomized trial, just a registry, and at the discretion of the physicians, they could place an Impella. This was the 2.5 device. In this group of patients, just to give you an idea, again, these patients had kind of already maxed out on other therapies. 88% had already had PCI, 70% already had a balloon pump placed. After placing the patients on the Impella, there was a significant improvement in their hemodynamics, as you can see here, with an increased blood pressure indexed and a decrease in their wedge pressure. If you look also specifically, remember about 68% of the patients had balloon pumps prior to the Impella being placed. So in those patients, if you looked at their parameters when they were on the balloon pump compared to after they were placed on an Impella, you can see that there was a 40% improvement in their blood pressure as opposed to when they were just on the balloon pump. And this was statistically significant. In terms of survival to discharge, in those with shock, the discharge rate was almost 60% and 90% in those without frank shock, which are pretty good numbers. If you look specifically at those patients who were in shock, who had AMIs, who received the Impella in the registry, there are 26 patients. 8 of the patients expired. 1 kept the device and got transplanted quite quickly. 12 actually recovered. 5 were bridged to another device, such as that CenterMag device that I showed you, of whom 1 was transplanted and 4 ultimately expired. from their baseline to follow-up of those that survived, there was a significant improvement in their ejection fraction with a 19% improvement. Perhaps one of the more exciting analysis in this group was the timing of the Impella support versus outcome. So they looked at the patients who got the Impella prior to the PCI being done as compared to those patients who had the PCI, then were deteriorating, and got the Impella placed at that point. There was no difference in their baseline presentation in those two groups, but importantly there's a significant improvement in survival in those patients that had the Impella placed before the PCI. So basically you got them stabilized, preserved their myocardium, and in a controlled fashion you could treat the patient. And this is, we've actually found this at our institution, people with cardiogenic shock with ischemic cardiomyopathies, and we found we can get the VAD in, and then we have time and can do the revascularization later. I'm going to just skip ahead in terms of due to time, but we have a significant experience at our hospital with both ECMO and the ventricular devices that I showed you earlier, and about 20% of the time those patients are treated with those patients. The indication for those devices are acute MIs. So, in summary, in these cardiogenic shock patients, while these devices do improve hemodynamics better, there's no significant clinical impact in terms of survival and perhaps with more complications. So there's really no benefit of these devices over balloon pump at this time, though I think there are patients which we probably feel that it's appropriate. I think there may be a benefit to placing these earlier, perhaps in large MIs, and we actually are currently planning a study where in patients with large anterior MIs we'll be placing these devices prior to the PCI. Thank you.
Thank you, Dr. Mathew, for excellent presentation. These devices, LV assist devices like Impella, are really useful for patients who are really sick, even in IABP, those who do not respond. But timing is more important. I think if you use it even before PCI, I think the result is much more encouraging. We have these Impella devices available in India. Few centers we have used it. But we have really used in the really sick patients where IABP has failed, and those type of patients, I think Impella's role becomes restricted. I think it's to be planned to use, but before angioplasty, the result will be much better. Thank you very much, Dr. Mathew.